This is Selma Schimmel at the 33rd San Antonio Breast Cancer Symposium. We're joined now by Dr. Clifford Hudis. You're the Chief of Breast Cancer Medicine Service at Memorial Sloan Kettering Cancer Center and Professor of Medicine at the Weill Medical College of Cornell University in New York City. It's great to see you again.
And it's great to be here again.
Dr. Hudis, to give a retrospective and sort of perspective view on adjuvant chemotherapy, when you go back in time to the early 1980s when Dr. Bernie Fisher and Dr. Gianni Bonadonna were involved in the early adjuvant like CMF studies, and now here we are today, all these years later. Maybe you can give us that little historical overview and with the highlight of where we're going.
Sure. So I think it starts the very beginning. This is, in fact, as you rightly point out, with Bernie Fisher, who had the hypothesis that breast cancer was microscopically metastatic, undetectably so, long before the patient met the surgeon. And the implication of that, which is profound, was that no matter what operation one did, there would be a limit to how many people could be cured. And the inverse of that is the only way to improve the cure rates would be to deliver medical therapy that covers the body head to toe, hence the term systemic therapy. Because unlike the surgeon's scalpel or the radiation beam, we can't aim our drugs to a particular organ or site when we don't know where the involvement is. So that's the birth in concept of adjuvant therapy. And it, of course, immediately went in two obvious directions. Hormone therapy for the cancers likely to be hormone responsive, and we've got that pretty well worked out, although there are interestingly new questions being asked about who really needs hormone therapy. And that's, of course, on the basis of hormone receptor status. And the alternative was chemotherapy, which was really for virtually everybody else. That is, the tumors that were hormone receptor negative in the early era, more recently those that we defined further by HER2 status. And the earliest trials involved single agents that were given for brief periods of time with minimal effect, empirically developed combinations. I want to pause on that because what we're really in the throes of right now is the development of translationally relevant drugs. We find targets, we find drugs that work against those targets, we prove them in the laboratory and we bring them to the clinic. It's just a fact that the earliest chemotherapy drugs didn't really go through that process. They were broadly able to kill cancer cells, but their specific testing wasn't the same. And they were combined, you mentioned CMF, they were combined largely because they could safely be combined, which is not the same as saying we're combining them because they're so effective. And so CMF was born, and the earliest days of this were prolonged exposure to CMF. We slowly learned that less was as good as more. And then we added the anthracyclines, which were either equivalent or slightly better in various studies, and globally have been slightly better, albeit at a price well known to everybody, a little more congested.
Adriamycin.
Right. The anthracyclines are both adriamycin, that's the brand name of doxorubicin, and ebirubicin. And then the taxanes came along. And with each iteration, we've gotten a little bit smarter so that we ask more nuanced questions. It isn't enough to say, do we give this drug, but is there a better or worse way to give the drug? Are there ways to support patients through the treatment so that while we make more effective therapy, we make it somewhat less toxic? And we've in fact done that. Growth factor support has allowed us to give, if not higher doses of chemotherapy, which really have not been beneficial, they've allowed us to give it more compactly and avoid the routine side effect of fever and infection. Similarly, we've proven that dose escalation is unnecessary, so we don't need to give the maximal tolerated dose of chemo, we need to give the right amount. And these kinds of experiments go on, in particular for triple-negative breast cancers, but for other types as well. It matters that we give chemotherapy, and in the story that I began this little session with about capecitabine speaks to that. Even after all these years, it's still apparent that there may be some advantages to be gained. Interestingly, one of the other abstracts presented at this meeting was TAC versus FAC from a Spanish group. This is a 10-year follow-up of a docetaxel, that's Taxotere, adriamycin and cyclophosphamide versus 5-FU adriamycin and cyclophosphamide. From some people's point of view, in this day and age, it's an old and resolved question. But there was a 7% survival improvement. Fundamentally, just getting the taxane, between 1 in 20 and 1 in 10 patients are more likely to be living 10 years beyond because of this. this is a big gain and not to be trifled with.
Dr. Hudis, as we move more and more into the area of biologic therapies, do you think that the role of combination biologics with chemotherapy will sustain itself?
So this is a very hot topic this year, and it's related to adjuvant therapy because it's related to where we test these combinations. The best example in breast cancer right now is that of Kim Blackwell and Joyce O'Shaughnessy over the last year, where we saw that both lapatinib, Tykerb, trastuzumab, Herceptin combined actually extended survival for the sickest patients, those patients with lots of prior therapy directed against HER2. That's no chemotherapy, that's just 2 biological therapies. And so what we saw this morning was a series of studies, some of which looked at the combination of 2 biological therapies or 2 biological therapies plus chemotherapy. It's pretty clear that we can't completely walk away from chemotherapy. The highest response rates were generally seen with chemotherapy and the combination of biologics, but there is a lot of promise there. If we can't get away from all chemotherapy, we may be able to get away with a lot less chemotherapy. Now, the last thing I have to say is there's going to be a lot of discussion about these studies because what they demonstrated in most cases was differences in the shrinkage of cancer in the breast. Let's be really clear. These were patients who had cancer that could be operated on but had not had an operation yet. So while the tumor is still sitting in the breast, rather than rushing to the operating room, they got these therapies and we can assess the activity. The challenge for us, and it's not a small one, is to prove that these differences in shrinkage in the breast directly relate to differences in survival, if you will, out the back end. Because if we can show that, then these kinds of pre-op studies can become the place where we do our drug development. And if we can't show that, then we're left with what I alluded to before, which is the challenge of these multi-thousand patient adjuvant trials.
Is there any other study you want to comment on, a question I forgot to ask, or any closing thought? Because this historical overview is really beautiful.
Oh, thank you.
Elegant.
I mean, the only thing that I would add is currently the zeitgeist is for these targeted therapies and for patient selection and subsetting, and I am completely for it. That's where most of my research is as well. But I do think that everybody needs to remember that there's been a falling death rate since 1990 in the United States from breast cancer and in most of the Western world, and that this is at least coincident with the broadened and more even application of chemotherapy. So we argue about whether it's from mammography, we argue about whether it's from radiation, and we can argue forever. The fact of the matter is that there's a temporal association between the broad use of chemotherapy and this falling death rate. And so as much as people are concerned about chemotherapy, and I, along with all of them, want to minimize its side effects, one should recognize that it remains a critical life-saving component of cure for patients with early-stage disease.
Do you think there will come a time that we can maintain the benefit of chemotherapy but reduce the toxicity of chemotherapy?
I think that we're incrementally along that way already. In the adjuvant setting, we've done it through the identification of lower dose regimens like weekly paclitaxel, the use of growth factors like Neupogen or Neulasta, which people know prevents some of the side effects. But I'll say one more. In the presence of the biologics, it may be that we need a little bit of the broad cell-killing effect of chemo, but not as much as we used to. And so we may find ourselves able to give a single modest dose chemotherapy along with biologics and get more of what we've seen in the past. That's something to consider.
That's interesting. So dose adjusting, just you'll get benefit, but minimizing some of the...
Well, I can take it half step further. In the setting of trastuzumab, we have some evidence in HER2-positive breast cancer that one chemo is pretty much as good as the other, and often as a minimal amount of chemo is as good as a lot. That's one example. It's not absolutely proven yet, but if that's what it turns out to be the case, you may need to, if you will, insult or damage cells with chemo and then have targeted agents that really prevent their recovery.
Thank you, Dr. Hudis, especially for that historical overview of adjuvant chemotherapy. That's really fascinating. Always great speaking with you. Dr. Hudis is the Chief of Breast Cancer Medicine Service at Memorial Sloan Kettering Cancer Center in New York City.
Thank you very much.